Hello, everybody, and welcome to another Wellness Wednesday. I have Dr. C here again with us. She's going to be a regular on our show. She always has Dr. C's 6 healthy habits, but I think there's way more than 6, Dr. C. I know that, we're trying to narrow it down to the sleep and the nutrition and those type of things. But every time we decide to talk about something, we get excited about the next habit or next information that you want to share with the public. So welcome again, Dr. C. How are you today?
Thank you. Welcome. Thank you for letting me come on again. And you know what? I mean, Dr. C's 6 healthy habits, kind of catchy, right? So you got to hook them with something catchy. And then each of those 6 healthy habits just then expands into a whole bunch of stuff. So what's the topic today? On Wellness Wednesday?
Well, I think that medications, I think there's a huge, I think there's a gap there with information maybe, and you're ready to share information about medications, different types of medications. I know that there's way more into medications than what we got allotted probably for today, for special blood testing that you can do to see if their medications work with you. But yeah, I think that medications would be a great topic. I think they're important. So
it's the one thing that nobody wants to take, right?
Right. Yeah. I mean, I personally wouldn't like to have to be on a lot of medications, right. But hey, if it helps you, then you have to do what you have to do.
So the reason the genesis of Dr. C's 6 healthy habits came about because there are certain key behaviors that in the world of prevention and, heart attack and stroke prevention, but also so much else, is that there is what I call a 2-way, multi-pronged list of things. I mean, there's things that I, as your physician, should be recommending based on who you are, what your circumstances are, but then you as the other half of that equation has a responsibility, right? And that responsibility is to do the recommended lifestyle choices, but also the choice of taking medications that are not just for one thing only. These medications have what we call pleiotropic effects. That means one medication can do a whole bunch of other things. So you're getting a bigger bang for your buck, if you like, right? Bigger bang for your oral tablet, if you like. So, when we talk about heart attacks and strokes, most people think cholesterol, blood pressure, maybe diabetes even. But cholesterol seems to be the major thing that people think causes heart attacks and strokes. Well, cholesterol, as you know, and most people know, falls under an umbrella where people have heard of total cholesterol, LDL, which I call lethal cholesterol, HDL, which is healthy cholesterol, and then triglycerides, which I call like the cream or the fat in the blood. All of these are necessary in our body, and we make some, but then we sure love to consume them, right? So it's important to have some, but not too much, because should you have inflammation, and we did talk a lot about inflammation in one of our previous discussions, yes. The combination of inflammation and cholesterol is where we can really get into trouble. So, I'm in Texas, and I guess this is a little controversial, but we like our guns, right? Yeah. So imagine you have just a regular gun on the table, fully loaded with the safety cap off. You're sitting on one side of the table and I'm sitting on the other. Is anything going to happen to us? No, because the gun isn't doing anything. So if you imagine the gun being the cholesterol, then the inflammation is the trigger. So it's the trigger that really impacts what is going to happen. So the other thing is, so it's important to understand that it's not just cholesterol. It is the combination of cholesterol and inflammation. And inflammation, as you know, can come from a variety of places.
So, Dr. C, one of the things that I learned from you a long time ago, because I had a lot of extensive blood work done, was the particle size in the cholesterol too. Like that's a whole other ball game there. I mean, if you think about it, I was amazed by that. So maybe we could talk a little bit about that too. Does that help? Is that the same wavelength of the inflammation pool? Yeah.
Right. So briefly, if you imagine a blood vessel and you go inside the blood vessel and it's like a little tunnel, that lining inside that blood vessel is only one cell thick. It's called the endothelium. And that endothelium acts as a filter of allowing certain things to come in and certain things to go out. Now, what we have noticed over time is people could have normal cholesterol and still have heart attacks. aka my father. He had normal cholesterol and had a heart attack. So what's the difference? And what we found out, long story short, is that if you imagine a wooden floor and you've got slats, and in between the slats are gaps, imagine the smallest, densest, bad cholesterol LDL particles can seep in there and sometimes get stuck. There's a whole other talk about LP little a and the genetic control and stuff, but essentially you start accumulating cholesterol plaque. But the big and fluffy ones don't get in there. So there's difference in density and sizes. So it does matter how big and how dense you are. And that also goes for healthy cholesterol. So that's kind of a whole new window of stuff. But one thing that most people need to know is that LDL is not the actual number of particles of cholesterol that you need to be worried about. It's calculated. So you don't go around counting LDL particles. The reason why is LDL is a big old particle made out of subparticles. God, this sounds really geeky. But it's the most important thing is
important to know.
Yeah, the most important particles on that LDL is ApoB, apolipoprotein B. And I like to keep things simple. So I think about B as bad, and ApoB tends to encourage and make more plaque. Mm-hmm. And if you get an ApoB level, that's more accurate than an LDL level. So when we talk about advanced, we talk about all these different things. Mm-hmm. And, you know, God made yin and yang and positive and negative. So there's also an ApoA1. And A1, I think, first class, really good, right? And that one removes plaque. So you need a lot of ApoA1 and you need not so much ApoB. So that's what really dictates to me when I'm talking to a patient and the patient says, nope, I'm not taking a cholesterol medicine. When I show them the ApoB and I say it's high, even if you take the medicine once or 3 times a week, it's better than nothing. I have a little joke. It's better to lick the cholesterol medicine than not take it at all. So the reason why the cholesterol medicine is so good is primarily it lowers inflammation. Now that's a paradigm shift. Mm-hmm. If you have high inflammation and taking a statin, like, I don't know, different ones, but my go-to one is Crestor, rosuvastatin, it will lower your LDL, total cholesterol, triglycerides, but also it will lower inflammation from many places. And people don't realize that. And so, you know, you may have very normal cholesterol, but your inflammation is way high. I'd give you a tiny bit of cholesterol, right? So there's also, different types of cholesterol medicine. I mean, you guys can rattle it off. Lipitor, simvastatin, Pravachol, Crestor, and now there's some even bigger and better ones, right? But the one thing I wanted to say is if you have to take a cholesterol medicine, there's a couple of things that can help guide you, all right? So there is a genetic test, and I know we are going to talk about genetics later on. but it's called the HIF6 gene. It's a blood test. You do it once in your life. And depending on your results, the genes will recommend or do better with certain medicines than others. Now, in general, though, I really like the rosuvastatin, and there's a reason. It lowers the risk of heart attacks and strokes in both men and women. It actually can reverse some of that plaque buildup. So how do we look for this plaque? One test that you remember is the CIMT. It's an ultrasound, right?
Yeah.
And look at how thick the wall is, how much plaque. But by taking rosuvastatin once a day, you can actually over time see that plaque get thinner. And the other thing is that there are 3 types of cholesterol plaque, all right? There is the very young, full of cholesterol, soft plaque, right? It's almost like squishy butter, okay? If that's on fire, or if that's in an environment of a lot of inflammation, then that can really cause trouble, no matter who you are, how old you are, or whatever, if given the right circumstances. Then the next type is the calcified plaque. So you've all heard of the coronary calcium score. What that is to me is just like a footprint that there was a plaque there, but there isn't anymore, because once you remove that soft plaque, and how do we do that? We take a statin, and by the way, the statin will put out the fire. You're left with a pretty much dead plaque, and it's calcified. So it means you had something, but it's not as dangerous as the other one. Then the third type is a mixture of both.
Okay. So, I mean, I've read Beat the Heart Attack Gene, you know, I'm very, very familiar with what they call the tennis court and the cracks in the tennis court. Which is a great book, and that's where we stem the Bale-Donine method, which is where we stem with in dentistry for me and working with you. Now the soft plaque that's in there, if it's dislodged, that's when you have an event. So you can either have a heart attack or a stroke. Explain that a little bit, because I don't know, that's just fascinating to me.
You could have a plaque that looks like a pimple. You remember when you had the really juicy pimples that were so thin and so white and you just wanted to go like this? Imagine, say for example, you're pre-diabetic. So you're not diabetic yet, but you have sugars every now and then that are floating through the blood vessel. And I picture it as shards of broken glass. So if you've got shards of broken glass and you've got this little soft ripe pimple, just a little scratch will open it up, will expose it as a wound. The body doesn't like open wounds. And so then all the machinery, all the blood cells will come in, and then things like platelets will go ahead and plug it up. The problem
is inflammation, the inflammation cascade.
And if you have a lot of inflammation, it's not just the local fire department that will come, it's the complete state. And so you've got an aggressive reaction to that small, tiny ulcer. And that's where you get the blood clots, heart, brain, leg, anywhere.
Yeah. I just think it's important. I think, absolutely. I just think that in general, when you're a physician, you're talking to somebody who has no idea, like what we know, it's a visual that I feel like is important to learn, like really what is going on in those blood vessels, and why does that happen? Like, like people like that are super healthy and then they have a heart attack. Like there's been a few stars that been like, oh my gosh, they're fitness gurus, but yet they have a heart attack.
So don't look at someone on the outside and think that they're healthy, because we don't know the state of their blood vessels. We don't know what kind of mental, emotional, physical stress or inflammation they're going through. And so imagine the marathon runner. And at the end of the marathon, he collapses and maybe has a heart attack and dies because the inflammation is so huge that having just a little bit of a plaque, not an occlusive, blocking the blood vessel kind of thickened plaque, no, just a little bit. So it's really important to know where you are in the whole world of prevention.
Yeah.
Right. And I know that Bail Donin, who has pioneered that view of heart attack and stroke prevention, have a lot of graphics. So maybe we can tag on some graphics later on.
Yeah.
But so statins, rosuvastatin, they will actually help make that plaque smaller. And this is not exactly accurate, but I like to feel like it will pour concrete over that plaque, so then nothing will dislodge it. Make sense? Mm-hmm. So even taking a little bit of a statin can be life-saving for certain people.
And Dr. C, when you said that the statins are also putting out the fire or the inflammation, is that something, because I personally haven't heard that ever, working with you throughout the years. That's you saying that to me. I didn't know that till right now. Like, I understood how statins worked, and but it actually is decreasing the inflammation.
Did you know that taking
cool.
it can also lower periodontitis? Because what is itis? It's an inflammation,
sure.
Right?
Sure.
It's not going to make it go away, but it will definitely help towards putting some of that fire out.
Can I ask a really technical question? And you might, how does it help do that? What is it in there that is in that statin is it because you're lowering the
you're basically lowering the cells in the blood that are responsible for mounting an inflammatory attack.
Okay, I got you.
Any more detail than that, I'm going to have to defer to somebody else. But
okay.
The way I know it does it, this is not a super duper double blind whatever study, but when you measure a high sensitivity CRP, which is looking at the level, the snapshot of the amount of inflammation you have on the day you give the blood, and you have, say, an elevated ApoB, but your LDL is normal, I might put someone on a low dose statin, recheck them in 3 months, and you'll see that has gone down. The ApoB's gone down and the high sensitivity CRP. But also confounding, by this time, people know that they should be sleeping, they should be eating, they should be, managing stress. So there's a lot of things. It's so powerful what you as a patient can do in conjunction with the medicine. And I say it's negotiable. It doesn't mean you're on it for life, but until your numbers and your imaging shows that you're in a safer place, then you can talk about coming off it.
Sure. We talked about the imaging, like the CIMT. I don't think a lot of people know what that is.
No.
I think we should explain that a little bit, because we talked about it and like you seeing your arteries. I've had it done twice. So I understand it, but go ahead and talk about that, because that's super important. I think that's huge, a huge thing.
It is. So if I am trying to find out what situation your blood vessels are in, how do I do that without opening you up? So there's 2 tests. There's the coronary calcium score that is more of like a type of CT or an MRI that you can get scanned and they'll look at your heart. Mm-hmm. But the reason why CIMT is extremely important is because the test itself is non-invasive, safe, and it's really quick and inexpensive. And it's a good way to mark once a year what's happening, what the effects of your lifestyle, the medication, the supplements, everything that we're working on, what is the effect? So you have a blood vessel, and we talked about going inside the blood vessel. There's a corridor through which all the blood cells go through. Most of us know that we're in trouble when that corridor narrows, where you've only got a 30% or less room to flow through, right? Or a 70% or more blockage. Mm-hmm. That's when we've heard, okay, now is when we have to do stenting or bypass surgery or anything, right? Mm-hmm. So the paradigm shift for us as Bale-Donine is, if we look at the thickness of the blood vessel wall, we can identify that there's going to be disease much earlier, and therefore, isn't prevention better than treatment? And so we look at the wall of the blood vessel to assess how does it compare to you and your chronological age versus your vascular age. And the goal is to be not more than 5 years older. So if I was 20, then you don't want to be more than 25, right? Mm-hmm. If you were 20 and it was 50 years old, then you know there's that's a lot of inflammation. So CIMT stands for the carotid intermedia thickness, the thickness of that section of the blood vessel wall. Mm-hmm. All right. When I do those tests, which you do one on left side, one on right side, and the carotid artery splits into two around the ear, and it's the external carotid artery and the internal carotid artery. And that better be careful which way I put my two fingers. That area here is where there's a lot of turbulence. And if there's any plaque, soft plaque there, then that's kind of a higher risk of breaking off, maybe going to the brain or something. So it's a test we do every few months here. We recommend that all our patients do it once a year. It's 15 minutes, in, out, done. And that gives us a lot of information of where you are now. And then next year, of all the work you've done and I've done, how is that changing? Is it getting worse or is it getting better? Yeah. And it's amazing. I've seen people where they've had plaque, soft plaque in their blood vessels. The next year it's gone. So it's very gratifying to see those improvements on CIMT.
Yeah, and I've had it done twice. So I mean, and you know, I love learning my artery age, right? So right. And just working where, you know, being a dental hygienist when I was working at Stonebar Smile Design, I mean, Dr. Wade's always recommending CIMTs for her patients because, you know, we're trying to find inflammation, hidden dental infections and stuff like that, and preventing heart attacks and strokes. And you know, we would have a person come into our office and do it. And we let all of our patients know that it's available. And then we would send them to the, you know, someone like yourself. And so that
somebody has to know what to do with it.
Yeah. Right. Super important. And I think that, you know, this information, it needs to be out there because it is really simple. It's just a nice little, you know, massage on your neck and you know, you can see everything. So thank you for explaining that. So statins, let's get back. Statins, we got ACE inhibitors. We got all kinds of medications here that we can touch base on. And
I almost feel like we need one show for each medicine because there's so much in each medicine. Now, statins are not benign, right? Mm-hmm. They can cause inflammation in the liver. They can irritate the muscles. And so that's what I hear a lot about, people having muscle aches, back aches, and so on. There are a lot of people that think statins cause diabetes. So let's look at that for a minute. I think some of the tests were done on cholesterol medicines like Lipitor or atorvastatin. And I'm not sure if it was, okay, you take Lipitor, now you've developed diabetes, or whether you were really pre-diabetic all along, and then you develop, it takes about 10 years to develop diabetes, and then it comes along. There is no evidence that the rosuvastatin that we use does do any of that. The myalgias, the muscle aches, that is a very genuine thing. what we find is sometimes, especially if you go to cardiologists, they see your risk and they do all their good stuff, but they will put you on a very large amount of a statin. And that sometimes is difficult for people to take because they have the myalgias, and then they think, I'm allergic to it, I can't ever take it. What I suggest is that instead of taking a large amount, and they have plenty of data that says large amounts prevent heart attacks and strokes, is to start them on the lowest amount, just like I would do with any medicine. Start low, go slow, right? And I would start them on the lowest dose, but to prevent the myalgias, I would recommend you take it at night and you take it with CoQ10. CoQ10, so if you're around 200 pounds, you want to take about 200 milligrams of CoQ10. Why? Because when you take a statin, it actually lowers the amount of the raw materials that those little mitochondria in every nucleus of every cell, they are busy churning out energy in the form of ATP. Statins will lower that. So if you don't have enough ATP in the body, you might not have enough energy. So what we do is we supplement it with the CoQ10, which helps it retain that. But also we found out that should you have a heart attack, that CoQ10 will almost behave like a little barrier. So you know how muscles start dying and it spreads and spreads? It will contain that spread. So it's very cardioprotective. And then the other thing is vitamin D. So vitamin D, CoQ10, your statin, take them at night. So that's how I get around the whole thing about muscle aches. And then the hepatotoxicity or the liver inflammation, that's why we doctors have to see you every 3 months, make sure you're doing okay, make sure that the level of liver enzymes are not going beyond a certain point. So you got to be careful, like, are you drinking? Are you taking Tylenol and stuff like that? You can't take it if you're pregnant or you're breastfeeding. And I do believe that this will contribute towards less what we call vascular dementia. And dementia is a huge thing nowadays, right? So if you're looking after your blood vessels and making sure that there is good free flow of blood in all the 60,000 miles of arteries and veins, then you're protecting that much against having buildup in the blood vessels in the brain. So think again when you talk about statins. I mean, there are negatives, but there's a ton of positives.
So some takeaways for this topic. We have inflammation.
Inflammation. Remember that ApoB is the real culprit.
Okay.
You don't need to start a very high dose. Just start on a little bit and see how you tolerate it. But do optimize CoQ10 and vitamin D and take it at night. And it will do its thing day in, day out, while you're busy doing life, and it will help protect your blood vessels.
And if you're taking the CoQ10 and the vitamin D and you're still having muscle aches, then you would need to go back to your doctor and
yeah, I would say cut back to, well, first of all, stop, get rid of the muscle aches, and then reintroduce it at the lowest dose once a week. If you can tolerate once a week, then go to twice a week. If you can tolerate twice a week, then do 3 times a week. Remember, it's better to take a little than nothing. And then you're supposed to be doing all your other stuff, right? So it's not just that the medicine will lower your cholesterol and inflammation. There's a lot of other stuff that you can do. But even taking a little bit, there is a benefit to it. So do think again about it and do have an open mind about it.
And then a CIMT. Look into that. Like, I mean, you're in Frisco, Texas. You know, you can't, you know, people are going to be watching this that are not over in Frisco or in Texas, but
you can always fly in and get it done if you're going to be visiting Dallas. But yeah, I mean,
definitely. But you could look for somebody who maybe, in your area, or just search it? I mean, how could you?
Bellarmine has a directory of doctors all over the nation. We need to really spread the word, because we need more and more doctors. And actually, I'm quite proud to say that I will be bringing my colleague to this year's Bellarmine preceptorship and reunion. And he is Dr. Shidlovsky, who is a neuro-optometrist. And he's going to teach us, if there's so much going on in the mouth, what's going on in the eyes that we can see.
Yeah, that'll be, I would love to listen to that. I mean, we should get him on, all three of us together on one of these wellness.
Yeah. And so I kind of feel like we are the three amigos, Dr. Wade, Dr. Shidlovsky, and I, and have to kind of approach things from different areas for the same outcome. Yeah.
That's fascinating to me. I had some LASIK done, which was amazing. Because I mean, just because you're talking about eyes, it just reminded me, I was wearing readers. I think you remember, I was like, oh, I can't see without my readers. And then I had LASIK done just because of old age. And it actually worked. I know when I'm in my, late 40s, I'm like, oh, I can't see. And so now I had it done and it works really well. I can see,
so
a lot
let
better.
me tell you that sometimes with LASIK, and I'm so happy you're doing well, but one of the side effects could be dry eyes. But then also, whether you do LASIK or not, you could be suffering from dry eyes. So Dr. Shidlovsky has this amazing laser, and the theory is that the inflammation on the skin, like rosacea and stuff like that, can manifest itself in the eyes. And that inflammation blocks the ducts that produce the oily part of the tears. So tears are made out of, I guess, like salt water and also oils. Those oils come from these glands right down here in the eye, eyelids. And I'm not an optometrist, but sometimes if they do get dried up or blocked, whether it's medication you're taking, hormones, or you have different things going on, right? A laser is now available to safely not only treat your rosacea, but also to treat the inflammation on the eyelids and underneath the eye. So not only are you helping to unblock by removing the inflammation, you're also getting a little skin tightening, collagen and elastin and stuff like that. So this is Dr. Shidlovsky's area. And so that has been life-changing for some of the people I know that have very severe rosacea and dry eyes. And here there is a solution that's not yet another drop or not yet another pill. So, there is a ton of stuff out there that can be so helpful. But be careful. There's a ton of stuff out there that can also be not so helpful. So we are in the wild west of medicine, and there are pioneers, and then there are not so good pioneers. So be careful. But that one has robust data behind it. But that's Dr. Shidlovsky.
Awesome.
Yeah.
Well, Dr. C, it's going to be so great to have you on again, obviously.
Yeah.
And maybe we'll do, we'll get all three of us together, and maybe all four with Dr. Wade, and that would be very powerful. So I hope everything is going well in Frisco, Texas with you. And
hot.
Is it hot?
It's summer in Texas. What can I say?
I used to love the summers in Texas. I mean, because I lived there obviously for quite some time, and I mean, it was always a fun time.
Come on,
there.
It doesn't compare to being by the beach. Come on.
Different.
Yeah.
Well, thank you so much. We didn't get to talk about the other medications, but maybe we'll do that another time.
I think we got a lot of things to talk about over time. So
tons of things to talk about.
As long as you got something out of this one, yeah.
Yeah, no, I think that, I learned something that was really cool. So, join us next time, for the next, I think next month we'll be another time that Dr. C will be on, unless I can get her to do another one sooner. But you're super busy. But thank you so much, Dr. C, again, for being here and sharing your wisdom. Really appreciate it.
Thank you.
All right. Thank you, everybody, for joining. Subscribe, like, all the information about Dr. C will be in the links below. You could, email her on her website if you have any questions. And again, thank you so much. Bye-bye.